introduction. Welcome to those who just joined. We'll give folks a minute to get logged in. If you want to go ahead and introduce yourself in the chat, we'd appreciate that. Andrea from Cook County, welcome. As others are joining, if you want to introduce yourself in the chat so we get a sense of who's here. Misty from West Central Minnesota, welcome. Happy that you could all join us. I think we'll go ahead and get started in the interest of time, but please continue to introduce yourself in the chat and we'll get rolling, talking about medications for opioid use disorder, talking with clients, families, and colleagues about facts versus fiction. My name is Keri Hager. I am a pharmacist by training, and I am an associate professor and associate dean for clinical affairs at the University of Minnesota College of Pharmacy based out of our Duluth campus. And as part of my job, I do practice 2 mornings a week as a pharmacist with our Center for Alcohol and Drug Treatment here in Duluth. So I meet with people and comprehensively review all their medications to see if everything they're taking is working for them, they're not having side effects or drug interactions, and then work with them and the rest of their care team to try to optimize their medication outcomes. If you haven't introduced yourself in the chat, please go ahead and do so. Glad that you're here. Our acknowledgements and agenda for the day, I do want to acknowledge there are many colleagues who have contributed to this presentation over time and folks who attended previous iterations of this presentation who have helped us refine it and improve it. And we're hoping you can help us do the same, and we'll complete our evaluation at the end. Sam's up for funding for the presentation, and then you all for showing up today. So I'm going to do a presentation. I like to keep things pretty informal so that it's useful for you. I'll try to keep an eye on the chat, but I'll pause periodically to check in to see if you have any questions. Feel free to raise your hand or unmute if you have questions. Have a couple of polling questions to engage you in the conversation, and then we should have plenty of time for Q&A at the end. Again, this really is meant to answer the questions you have and address the concerns that you have, so we can be pretty informal and we can adjust accordingly. So as we get started here, I'm going to launch a poll. Ignore this poll that's going to come up. I'm going to relaunch the poll if I'm able to. Maybe I can't. Relaunch the poll. Okay, so I'm going to launch this poll so you can select A through D. Just sharing your current understanding of medications used for opioid disorder, medications like methadone or Suboxone, buprenorphine, naltrexone. Complete, you can teach others, you know, fair amount, have a little to learn, don't know much, that's why you showed up, or you just think it's terrible. It's anonymous, so feel free to select your option. We'll give you a few more seconds here. And I'll go ahead and end the poll and see where we are. So it looks like of those who responded, majority don't know a lot, and that's why you're here, which is great. Some know a fair amount, but could learn more. So definitely share your insights as well if you already have experience on the topic, either directly or indirectly. We are glad to have you join the dialogue today. I'm on a laptop, lots of clicks and screens here. All right, so our goals for today are really to talk about these medications for opioid use disorder, summarize the research supporting their use, talk about stigma that prevents adequate treatment for opioid use disorder, and very importantly, leave with new ideas about how to talk with clients, families, and colleagues about medications for opioid use disorder and feel confident when you're having those conversations. If there's anything else that's not listed there that is a goal for you today or you think would be helpful, please feel free to chat it in as well, and we'll try to make sure that we address that and we can get to it later as well. So if there's anything else you want to make sure we talk about, any questions that you have, feel free to throw them in the chat. I'm going to kick us off with a patient story. This is a 6-minute video. It's one of my colleagues, Dr. Lisa Pruzak, who's a family medicine physician, talking with one of her patients about buprenorphine or Suboxone that she uses for her opioid use disorder. So this will be about 6 minutes, and then we'll resume our conversation. If you could indicate in the chat if you can hear this.
I just wonder if you could tell us about your life before treatment.
I started opiates when I was in college, and it was just, kind of like once a month use with a girlfriend, my roommate actually, and then we started doing it a lot more, but then we would stop, and all of a sudden it's like we would have these withdrawal symptoms. At the time we had no idea what withdrawals were, that we could become addicted to, our bodies would become addicted to something. I stopped for a couple years. I was still drinking, so I wasn't completely sober, but then I started back up again in my late 20s. I started using heroin probably 27 or 28. I mean, I was addicted full blown at that point. You're a slave to this drug that has completely taken over your life and you as a person. You're no longer, you're lying. I didn't know how to get help, and I didn't want it. I didn't know what my life would look like sober, and being an addict, period. It's like we're digging ourselves our own holes, because the shame and guilt for me personally was a lot of, well, I'm already lying, I'm already using, my friends already know, my family knows, like, I'm just gonna keep using to numb that, and it's just like this vicious cycle. I was getting down to my very last bit of heroin, and my mom had actually opened the door, and I was just out of it, but I was trying to shoot up, and she walked in, and it was like there was no hiding it. She already knew, but she didn't know to that extent. And I went to MOUD, I think it was 2 weeks or 3 weeks later, and I got in, and I had to go through detox again because I was under the influence. And once I got there, it was probably 2 weeks later where I was able to see a doctor to get on the Suboxone program.
So can you tell us then what it's like transitioning to Suboxone and how you feel on that and how your life is now?
The program, treatment, and Suboxone saved my life. I do feel like that is the truth, because I don't want to say it was just Suboxone or it was just treatment. Treatment gave me the tools and the resources in this area and within myself to be strong enough to overcome addiction and why I used. I wasn't sleeping. I was extremely uncomfortable in my own body, and it mellowed all of those withdrawals, but it also, and I still wasn't comfortable. I still wanted to use when I was first taking Suboxone, even though my urges weren't as strong. So I look at my life now and then how it was before, and I have had someone who has said, you're basically just, you're still using a substance, and I quickly was just like, yes, I am, but I'm also a completely different person than who I was when I was using. I would not work 7 days a week and have an animal that relies on me. I would not have strong relationships with my family, with my friends. So it hurts when someone says something like that. But I also see where they're coming from, because it is something that I take every day. And, you know, people can abuse it, and they do abuse it. I feel like if it's used properly, it can save a client's life, a patient's life, a person's life. I'm honest with my family. I'm truthful with myself, with therapy, with friends, with counselors, doctors. With Suboxone, you know, when you initially take it, it calms everything, and it clears your head, and it stops those withdrawals. And at that point, if you really do want help, that's what you want it for, is to get rid of the withdrawals. And so you can think and concentrate, and then you know, once you stay at treatment, or whether you're an outpatient or inpatient, you know, there's a lot of people there to help you and support you, and you get relationships back, and relationship with yourself back. And I think it helps. It definitely helps you do that.
All right. So I always like to kick it off because with that story, because so if I don't have someone live to share their story and their use of medications for opioid use disorder, because I think sometimes our interactions, or maybe things that have come up in the past related to these types of medications, maybe haven't always been good, depending on what type of role we're in. But I am here to tell you that as we work with folks, their stories of overcoming hardship and getting into recovery and accessing the tools they need to have healthy, good quality of life is quite remarkable. So yeah, I see the comment in the chat about it was powerful. Thank you. Any other reactions to that? Is that typical to what you think of when you think about somebody taking a medication for opioid use disorder or not? Does it, if you reflect back on your sort of your own bias coming into this conversation, or just in general, when we think about addiction, how does this story maybe relate to that? Or maybe it was counter to things you've thought before, and no one needs to answer, but just something to think about as we go through the presentation and talk about why these medications work. You may have seen something similar to this, but there's been this sort of 3 waves, they say, in death by overdose, in opioid overdoses. And I should clarify, when I say opioid, that's an umbrella term that includes any type of opioid medication, prescribed, non-prescribed, or illicit, or non-prescribed, or prescribed. So that would be like Lortab or hydrocodone or fentanyl that you get prescribed, or that's used when you have a procedure in the hospital, or oxycodone, those types of medications. And also opioids include things like heroin, or these synthetic, what we call fentanyl analogs, that are manufactured and sold illegally. Synthetic opioids, you may have heard of those. So the first wave in overdose death by opioids came early on, in the early 2000s, where we had this rise in prescription overdose deaths. And then as we started restricting those prescriptions, you see a change here where that sort of levels off, this purple line. And then you see in around 2010, you see this increase in heroin overdose deaths. And then more recently, this third wave, which is the synthetic fentanyl type opioid overdose deaths. And why you're seeing that now is because those opioids, those what we call like fentanyl analogs, are very potent. They're stronger than other opioids. And so a smaller dose can cause an overdose. And oftentimes people wouldn't be aware that there was actually fentanyl. Maybe they thought that they had purchased heroin and then it actually had some fentanyl in it. So they unintentionally overdosed because the fentanyl is so potent when they used it. I think Maggie's comment in the chat around the patient story reminding Maggie of the experience getting off heroin when they received Suboxone from their heroin dealer. which saved their life. I mean, think about that. We're going to talk about that a little bit later. So that was altruistic, we'll say, use, or it was not prescribed, it was used illicitly, but helped this individual go from using heroin, which may be contaminated with other things like fentanyl, to using Suboxone. Very interesting. So I look forward to having some more conversation about that throughout the session. Always a reminder that these numbers, you see the graphs, you see the stats, you see the colors on the map, but just remember that these are our sisters and brothers and parents and neighbors and friends, and sounds like we have some folks on the call today that have been personally affected by this as well. So just a reminder that we're talking about people in our community. And when I talk about opioid use disorder, I talk about or opioid addiction, and you heard her call herself an addict. We would call her somebody with a substance use disorder or opioid use disorder, but really it's the use of an opioid, and that can be a prescription or an illicit opioid that's compulsive, dangerous, or both. And it is not a weakness or a moral failing, and it can affect anybody. When we think about how do you describe what an addiction is, kind of the thumbnail is the 3 C's: craving, compulsive use, and use despite harmful consequences are sort of the hallmarks: craving, compulsive use, and use despite harmful consequences. And that's what addiction is characterized by. And it is a chronic relapsing brain disease. And that can be a helpful framework to think about this in. And that it's really complex as a disease. So when somebody is addicted to an opioid or has an opioid use disorder, you can think about it as sort of hijacking the biological survival systems. And you get this abnormal drive in your brain, and what we call your reptile brain, the part of your brain that you don't consciously control, the part of your brain that tells you, to breathe and eat, those types of drives. And that's where you're impacted when you have an opioid use disorder. And that's why it's challenging for people who are in withdrawal, and you heard Kat talk about that, to engage in some of the social, psychological, spiritual, and cognitive tools for recovery and treatment. If your reptile brain is telling you you're going to die if you don't get another dose of your opioid, it's hard sometimes to engage in those other types of interventions because you are experiencing withdrawal. And we'll talk a little bit more about that. So I think it can be helpful to think about it as your brain is hijacked, and so you actually aren't thinking clearly because you're unable to do that. It's not a simple cause, and I'm sure most of the folks here know that, right? So you have to think about the host, the individual person, their genomics, their genetics, the environment that they're in, their context, their ecosystem, and then also the agent. How does the agent, the drug, affect the body? And it's the intersection of those 3 things that results in different types of addiction, and it's different for different individuals, right? Based on a number of factors. So it's not a simple cause. In addition to the 3 C's we talked about, we also have 2 other symptoms that are part of the diagnostic criteria for opioid use disorder, but they, in and of themselves, do not make a diagnosis. And those are tolerance and physical dependence. And I think it's important to talk about these because I think there are people who use opioids chronically that will experience tolerance and physical dependence, and that's expected when you chronically use opioids. So tolerance means you need more of the same medication, a higher dose to get the same effect. So maybe 10 milligrams used to control your pain, but now you need 20 milligrams to control your pain, as an example. So that's tolerance, when you need that higher dose. Physical dependence is when you can only function normally in the presence of the opioid. So you're dependent on it, your body needs it, and if your body doesn't have it, you're not able to function normally. So those are 2 of the pieces of the diagnostic criteria for opioid use disorder, but those 2 are expected with chronic opioid use, even if it's not a use disorder. And then I see the comment, about other causes include systemic racism and systemic discriminatory systems. Thank you for that comment. I think it's really important. So we have this model the chronic brain disease, as we talked about, and the different, the host, the agent, and the environment. And it can be a valuable framework, but also it can have its flaws. And I think with the point that you're bringing up that's so important is the system and the environment in which one is, right? Rather than you as an individual have this disease, what is the disease of the system or the community that's impacting that individual? And so I've thought a lot about how we can frame that in a useful way for people to recognize that they are a product of the system and in the environment that they are brought up in or are living in, right? And so there's those external factors influencing them and their choices and their abilities. And then there's the individual pieces where what can we help that individual do, maybe with a medication or with different types of treatment to help them. So I appreciate that comment. And I think maybe we can, as we get further along in our discussion, talk about how to balance those two things. I've had that conversation with some of the Indigenous folks that we work with as well about that individual versus the community, system, and environment. And how do we talk about those things and think about those things in a way that helps improve them for the individual and for the system and the community simultaneously. So it's a really good point. Let's come back to that for sure. This was really helpful to me when I was learning about addiction and opioid addiction specifically, and actually not even opioid addiction, opioid dependence. This is kind of something you can scratch on the back of a napkin or a piece of paper when you're explaining to somebody what happens when somebody develops opioid dependence and why we use medications for opioid use disorder to treat that dependence. So on this graph, on the vertical axis here, this is how somebody is feeling. So euphoric or high, happy, kind of okay baseline, sad or dysphoric, which is feeling bad. And then from left to right on this horizontal axis, this is as time goes by. So for a healthy person, you'd have, some normal variation in mood, kind of some ups and downs generally around that baseline is where people are. That's normal variation, but kind of, always coming back around that baseline. Intermittent use in a non-susceptible brain, you get the high, maybe a little bit of a dip, a hangover, so to speak, and then you can go about your day, go about your week, go about your month, and then use again sometime in the future and have that euphoria, a little bit of a dip, and then come back to baseline. So this is intermittent use in a non-susceptible brain. But then we think about someone with a susceptible brain and also more chronic use where you initially maybe use that opioid, you get that high, you get the little bit of a dip, but with each subsequent use over time, your brain starts to adapt and get dependent on that opioid such that you're starting to get less and less of a high and spend more time down here in dysphoria or withdrawal. And eventually you're using just to get back to normal, right? So if you're not using because your brain is dependent on this substance, you can't function normally without its presence. So you're down here in withdrawal. Susceptible brain. So we don't know the details. The science isn't figured out yet, but some people seem to be, and that could be related to genetics, environment, but more susceptible to dependence and addiction than other people. I think about it as, different people react to different medications in different ways, and we are not, what's the word I want to say? It's not as well defined or as clear as we would like for different individuals. So just to say, some people are more susceptible, some people less susceptible, likely having to do with their genetic makeup and other factors. So I think there's a lot to be studied and learned. That's all I meant with susceptible versus less susceptible or not susceptible. Hopefully that helps. Yeah, you bet. So I'm going to go back a slide actually. My slides will let me. Here we go. So we're talking about opioid use over time, right? And as your brain adapts, you get to a point where instead of getting that high you initially used to get, now when you're using, you're just getting back to that baseline or normal. So you're using to feel normal. Otherwise, you're down here in this dysphoria or withdrawal, which for an opioid, when you're in withdrawal, is basically pain and then all the fluids, watery eyes, runny nose, nausea, vomiting, diarrhea, sweating, craving, irritable, tremors, very uncomfortable. People say they feel like they're going to die. They feel very sick, vulnerable, scared. It can be very, very uncomfortable for people. And so again, we talk about with dependence, once people are dependent on that substance after having used it over time and their brain's adjusted, then they're using just to get back to baseline. And sometimes maybe they're able to, get beyond baseline and be high again, but some people are just trying to get back to feeling normal so they can function and go to work and take care of their kids or whatever they need to do. And that, and this is any substance, but it takes time to recover once you stop using, right? I mean, with alcohol, it can be a couple of years. There could be, like with methamphetamine, maybe not even all the way back to baseline, and it's different for each individual. So I think that's an important thing to keep in mind too. It's not like after chronic use of some of these drugs that you quit using and just feel fine again, right? It takes time to recover from that. It really depends on a number of factors, including what type of drug it was and how long you used and how much of it you used. So it's going to take some time. So people aren't going to feel great immediately. And so I think that's very important when we're working with people to be aware of that. Not only that, and the other thing is, once someone maybe gets sober or is using less, sometimes if there were issues that came up, maybe legal issues or relationship issues or work issues that came up because of the use or because of the use disorder, they may get into recovery or get sober, and all of a sudden now they have to manage all of that had gone wrong, and that can be really hard for people too. And if you put yourself in someone's shoes who is dependent or addicted to an opioid, would you stop? You don't have enjoyment in life without the drug. You feel awful without it. You only feel normal with it. You're craving and compulsively using it, and you can't stop thinking about it. It's sort of this automatic, your brain just gets you into the behavior. Even if you think and you don't want to do it, it's hard to interrupt that action of using. You're not really thinking things through. You have poor memory. You're feeling impulsive and vulnerable to stress. Maybe you don't have other ways to cope. Feeling hopeless. Basically, life sucks. And you have access to instant, reliable relief, even if it's only temporary, right? Versus trying to get into recovery, which can be a challenge. There's a number of, you have to navigate the bureaucracy of our healthcare and treatment systems. You have to have time, transportation, access, different types of supports. Maybe if you have children, you need to find a way for your children to be taken care of. There's a lot of different reasons that are barriers to recovery. And in my dream world, we would remove that red bar and it would be just as easier to get into recovery and treatment services as it would be to just use from something off the street. So I just want to reiterate one more time what dependence is. It's where you go over time, your brain adapts to the point that you only can get back to baseline and feel normal, quote unquote normal, if you're using. And so I think a really important point is this is treatable. Opioid use disorder is treatable. And so medication-assisted treatment, or MAT, or medications for opioid use disorder, or MOUD, you'll hear them used interchangeably, but is about using approved medication along with counseling and behavioral therapies as a whole person approach to treatment of opioid use disorder. And so the medications that are approved are different formulations of, methadone is one, and then buprenorphine or buprenorphine naloxone, which one of the brand names is Suboxone, might sound more familiar to you. And then the third is naltrexone or Vivitrol. I'm going to talk less about that today. We don't use it quite as much because it doesn't have as good of effectiveness as the other agents, but we can talk about it certainly if you have questions. I see a quote in the chat. Addiction usually isn't the main problem. It's the best solution to the problem at the time. Yeah. So, and once the drug is no longer there to help someone cope, the trauma rears its head again. Absolutely. And we know that a lot of individuals with substance use disorders have co-occurring other mental health conditions, depression, anxiety, maybe some schizophrenia, certainly some trauma, PTSD as well. So yeah, people self-treat with what they have available to them to take care of what they need at the time. Thank you for sharing that. So this is kind of the crux of the tech, and we'll revisit that, but this is just a very basic summary of what the data and the research tell us about why do we use MAT or MOUD. And what the research tells us is that it reduces opioid use, it reduces opioid-related overdose death. Additionally, it reduces criminal activity, reduces infectious disease transmission, and saves money. There's a return on investment for treating individuals with a medication for opioid use disorder, all while helping an individual improve their social functioning, retention and treatment, and their ability to access the much needed counseling behavioral health services that could help what their issues are. And we call this a harm reduction strategy, similar how we call like naloxone or Narcan, which is the overdose reversal agent, or syringe exchange programs. They're considered harm reductions, and MAT is considered harm reduction. But if you think about it, really all of medicine is harm reduction, right? We're trying to reduce harms and help people improve their quality of life. So this is no different, but again, we pick this sort of maybe stigmatizing language of harm reduction, even though really it's just taking care of people using an evidence-based approach. So this is a summary of the data. It's pretty good, and this is based on, this is related to buprenorphine and methadone rather than naltrexone, where the data aren't as robust. And harm reduction, if you're not familiar, harmreduction.org is a resource you see there, but it works to minimize harmful effects rather than ignoring or condemning them, which we found is not useful. And it's important to remember that opioid use disorder isn't a moral failing or a choice, and it can be helpful to think about it as a chronic relapsing medical condition that we treat over time. And to the individual's point in the chat, we shouldn't only think about this individual and this individual has this brain disease. We also need to think about the contexts in our communities where people are that may influence this as well. I do want to make a point about relapse. This was also really helpful for me to think about, and I use this as an education point a lot. So when I first got into addiction and treatment, I was like, retention and treatment, don't you just treat someone and send them on their way? Like, isn't like it a failure if they come back? And the answer is absolutely not. Just like if you have diabetes, we don't say like, here's some insulin, figure it out for the rest of your life, right? We check in on you periodically, more often if you need more support, less often if things are going well. So thinking about it in that framework has been really helpful. So when we talk about relapse, we're talking about somebody not meeting their goals, which could be a variety of things. And when you think about folks that use different types of drugs, there's a 40 to 60%, maybe a little bit more percent relapse rate. But if you think about other chronic conditions like diabetes or high blood pressure or asthma, those rates are very similar or even higher when people aren't meeting their individual goals for those conditions. And using diabetes as an example, maybe for folks that celebrate certain holidays, there's a lot of, cookies and lots going on around the holidays. Maybe you're stressed out because your in-laws are visiting and you're just tired of, checking your blood sugars, maybe eating more than you should, not taking your meds. And all of a sudden your blood sugars aren't at goal. You don't go to your doctor and they're like, shame on you, we're taking away your insulin. Good luck, figure it out, right? No. We say, hey, what's going on? What happened? We meet people where they are. Do we need to adjust how you're monitoring this? Do you need a different medication or a change in your dose? Would it be helpful to meet with a dietitian? Would it be helpful to meet with a therapist? We figure out where people are and we help meet them there. I think asthma is another great example. So oftentimes people will be on their medication to keep their asthma controlled, but then they're like, no, I feel pretty good. I'm going off my medicine. They go off their medicine and all of a sudden they catch a cold or RSV that's going around, and they end up in the emergency room. Right. And when they get there, we don't say, shame on you, you didn't do things perfectly. No, we give them a nebulizer and help them breathe and get them restarted on their stabilizer medication and make sure that they have the resources they need to stay healthy. So I think it can be helpful to think about this as you're working with people, especially if you're like maybe a medical professional that manages folks with chronic conditions, or maybe not, but to think like, would I act the same way or think about this the same way if we were talking about diabetes or high blood pressure or asthma. So how do these meds work? This is very basic. We'll try, I don't know that this is my best graphic, but so these drugs work different places, but I'm going to specifically talk about the opioid receptors in your brain, which affect that euphoria or dysphoria or withdrawal. So you have these receptors in your brain, and then all these opioids go to that same receptor. Some of them sit on that receptor and they stay there a long time. Some come and go, some activate it super strongly, some less so. Some are super sticky and can kick other opioids off. So they work differently, but they're all working on the same receptor in your brain called the opioid receptor. So methadone as a treatment, it sits on that same opioid receptor and hangs out and has a long time it stays in the body. That's why we only need to dose it 1 time a day for opioid use disorder. And it just activates that receptor, gets people out of that withdrawal and back to baseline. Buprenorphine, or there's different formulations. Some are tablets, some are films, there's an injectable, but Suboxone or Subutex are a couple of brand names. Suboxone or Subutex, buprenorphine, sits on that same receptor, but it just partially activates it. So there's a limited effect. So it's harder to have side effects on that than it is, for example, maybe with methadone or with other opioids. The other thing that's super important to know about buprenorphine is it's very sticky. So if you've used heroin or fentanyl, or you've been taking oxycodone or Percocets or whatever you've been taking, if you've been taking that for a long time and you still have it in your system, that buprenorphine gets in there and knocks it off the receptor, but doesn't activate the receptor as much. So guess what happens? You actually get withdrawal, or what we call precipitated withdrawal, because you're not getting as much going on at that receptor. So that's why if you've heard of people that are getting onto buprenorphine or Suboxone, we have to wait until they actually get in withdrawal and they haven't used for a period of time, because otherwise we can actually make the withdrawal worse. So we can do little doses to get them onto the Suboxone and off the other substance, but we want to wait until they're in withdrawal. And we can talk a little bit more about that as well. So it works, it's a partial agonist. We say it works partially on that receptor, but that Suboxone is super sticky. So it'll kick other stuff off the receptor that's already there. And then finally, we have naltrexone or Vivitrol. That's a monthly injectable formulation. And that sits on the receptor and actually blocks anything else from getting on the receptor. So it kind of acts like Narcan, but it's formulated a little bit differently. Narcan or naloxone, which is the opioid overdose reversal agent. So that sits on the receptor and prevents any opioids from getting to the receptor. So someone would need to get fully through all withdrawal a couple weeks after the last use before they could go on the naltrexone. Otherwise, they'd have that precipitated withdrawal. So that could be an option for individuals who prefer, for whatever reason, not to take methadone or the buprenorphine products, or maybe they have there's a few different types of employment opportunities that don't allow individuals to be taking opioids or even partial opioids like the buprenorphine. So it could be an option for people as well. I'm going to pause there and see if there's anything in the chat, or see if folks have questions about that. All right, I'm not hearing anything so far, but please feel free to interrupt me. So why MAT or why MOUD? So remember, again, here's our dependence diagram. We're down here in withdrawal. And what happens is that MAT, methadone or buprenorphine, brings you back up to baseline, gets you out of withdrawal so you can think again and feel more normal, so you can engage in other types of activities and treatment interventions. So this is sort of the money diagram. You can commit to memory and share with others. Heather Bells, who's a physician in rural Minnesota, we tell patients that MAT is your insulin, it's your blood pressure med. This is helping your brain function. So trying to destigmatize it and think about it as a medication, just like with high blood pressure or diabetes that you might be on for life. You might not, but thinking about it in terms of taking care of a chronic issue and just trying to destigmatize it. I saw some comments in the chat around, similar to like anxiety or depression or other medications that for mental health conditions that also have, folks might experience stigma around that as well. I think about it, I heard this and I don't know who to attribute it to, but this was related to antidepressant medications. But thinking about it as like, if you're like drowning in a lake, it's like the life ring that gets your head back up above water, but then developing other strategies or tools for, maybe some of the external factors or coping mechanisms or those types of things are like learning to swim to shore, so that it can be a both end. I don't know if that's a perfect analogy, but it kind of helped me think about, yeah, like this gets you part of the way or turns down the temperature on your anxiety, so then you can function and do the things you need to do and swim to shore. Here's some actual quotes from some of our folks at our opioid treatment program here in Duluth. My son got his mom back. I've not gone back to jail and paying my own bills. I have a bank account with money in it. I'm going to school. I have a home and a vehicle. And you heard this with Kat too. She has a job. She's taking care of her animals. She's repaired her relationships, not only with her family and friends, but with herself. So I want to get into it's to get our conversation going maybe a little bit more, some common misunderstandings. So it's poll time. This is our active engagement again. So hopefully you're still with us. I'm presenting on a laptop and I can't see any of you, if any of you even have your cameras on. So if you're out there, please respond to the poll. So the first one is MAT or methadone or buprenorphine should be offered to pregnant individuals with opioid use disorder. Let me relaunch this 1 second. I'm going to relaunch the poll. This is anonymous. Of course, we should offer MAT to pregnant individuals. I'm not really sure, or oh my gosh, what a terrible idea. Why would we give this to individuals who are pregnant? All right. Got about 40% response. We'll wait till we get over 50. Give you a few more seconds. This is anonymous. No one will know. All right. Well, maybe some of this education over time is working because yeah, more folks saying, of course, than I've ever had in a webinar. So that's good. And then I'm not sure, I think is totally reasonable. So we'll talk about this issue and whether or not pregnant individuals should be taking methadone or buprenorphine. All right, so here's our next one. Let me relaunch again the poll. Babies whose moms are on methadone or buprenorphine are born addicted. Yes, no, or I don't know. All right, got a mix across the board on that one. Yes, no, or not sure about that. Okay. And then let me go to my next poll. Individuals should taper off of their medication for opioid use disorder, meaning methadone and buprenorphine, within 3 months, 12 months, 24 months, or never. All right, with 56% reporting, we're going to call this one. All right, so it looks like a mix of within 12 months, 24 months, or never. All right, close the poll here and we'll dig into these a little bit further. So can medications for opioid use disorder be used in pregnancy? Absolutely, yes. It reduces, for the mom, it reduces the risk of overdose and death decreases risk of infection and helps increase prenatal care and recovery treatment, while also reducing the highs and lows and fetal distress that can occur from withdrawal of substances, decreases loss of fetus, and decreases preterm delivery. So yes, and it's a, and I will tell you from working, and probably you've worked with folks as well, but working with individuals who are pregnant, there's so much shame around pregnancy and drug use. And so shaming people doesn't work. So helping people engage in treatment, really supporting them to be as healthy as they can be. The healthier mom is, the healthier baby is going to be, and that the more likely they are going to be able to be together after the baby is born. So absolutely, yes. Much better for mom to be on methadone or buprenorphine than to be using opioids. And I hadn't mentioned this, but with the illicit opioid supply, so the heroin supply, other even pressed pills and things as well, there is adulteration or contamination with those synthetic fentanyl type opioids that are more potent, right? So sometimes people don't know what they're getting, and you also don't know what else is in it. So another thing that we're seeing in the drug supply now is something called xylazine, or trank is the another thing people call it. And it's actually a veterinary tranquilizer. And so what can happen is someone can use an opioid, like they think they're getting heroin, or maybe they even think they're getting fentanyl that has xylazine in it. And it causes them to be very sedated and to reduce their cognition and in combination their breathing. So you may have folks that aren't as responsive to Narcan with an overdose, and it could be because they have this xylazine. So my point in all that is, if you're using off the street, you don't know what you're getting, and it might have other things contaminating it. Not to mention, if you're injecting or using in other ways, it can increase your risk of a number of bloodborne conditions and infections, HIV, hepatitis B and C. It can cause blood infections. It can cause heart infections. So it's really important that we help engage mom in prenatal care and get her the treatment she needs to help minimize and reduce or eliminate any use. So yes, you can use medications for opioid use disorder in pregnancy. Here's a key point. Babies whose moms are on MAT are born dependent, not addicted, right? Dependent, not addicted, because they're not having compulsive drug use and using despite harmful consequences, right? So babies are born potentially dependent, not addicted. So I just want to take that out of your brain and never say again, and please correct people who talk about addicted babies. Babies are not addicted. They may be born dependent, and they may have withdrawal symptoms. And so that can be addressed when the baby's born. There are some basic things that they can do, like rooming the mom and the baby together, skin to skin contact, breastfeeding, quiet environment, sort of the things you do to soothe an infant anyway. And also, if needed, they can short-term use morphine or methadone for the baby to help them through that withdrawal. And then just to also point out that babies can also have some of these withdrawal symptoms with other things like antidepressants, with nicotine, et cetera. But the point is that if we keep mom healthy throughout the pregnancy, we keep her stable, mentally healthy, not using, that's going to be better for the baby, and we can manage that withdrawal. And another misconception I hear from pregnant women using methadone or buprenorphine is they think if they reduce their dose of methadone or buprenorphine, that it's less likely that their baby will have that neonatal withdrawal syndrome, but there isn't a direct correlation. So the best dose for mom is the best dose that works for mom to keep her from using, keeping her healthy. And so I would just encourage women, if you're working with pregnant individuals, that you make sure they get what they need to stay healthy and avoid use and not taper down. And in fact, in pregnancy, because of the physiologic changes, the changes in the body of the pregnant person, they actually may need a higher dose of methadone specifically. Sometimes we even have to split it and dose it twice a day. And they need that during pregnancy. So they may actually need a higher dose. And again, not correlated with whether or not baby will have withdrawal. And withdrawal is manageable. it can be hard to see, and I appreciate that as well, and it's manageable. So babies are dependent, not addicted. Should people taper off? So this, we had kind of a mix of responses on this one, and it's really not the goal. So if we think about it as a chronic, recurring, relapsing brain condition, it may be that somebody needs to be on treatment for life. It may not be. I think there is no research that says there's a specific time frame somebody should be on this treatment. So if there are programs, and I know that there are, that say, you can only be on for this amount of time, and then you have to be off, that's not evidence-based. So it really is individual. And I think there was a comment in the chat about that as well, as doesn't it depend on the person? Absolutely. So there's a number of factors to consider. And I do think it's important before someone starts on MAT that they are aware of that it may be that they will need to be on it, and that coming off of it may be a challenge as well for methadone or for buprenorphine. And we do have people that maybe start with one and it doesn't work for them for any number of reasons, and so they decide to switch to the other. Methadone is much more highly regulated. You can only get it at an opioid treatment program. So for Minnesota, that's Duluth, Brainerd, St. Cloud, Rochester, in the metro area. So for folks in greater Minnesota, that can be a challenge if they have to travel daily when they first start that treatment, can be a barrier for people. We all know that transportation and access is an issue for people with less means and who live rurally. So I think that can be a challenge. It can be a very effective medication. It can be helpful having to come in every day, every week, getting that support on site. People that come to opioid treatment programs get their methadone medication, an assessment by a nurse, and then they also get scheduled counseling with a licensed alcohol and drug counselor as part of those services. Suboxone or buprenorphine can be prescribed by other clinicians, physicians, pharmacists, or physician assistants who historically had to get waivered. So that's been part of the issue to access the buprenorphine. Now physicians can just complete some paperwork and be able to prescribe for up to 30 people. But still, it may be in limited quantity, and not everybody in every clinic yet prescribes buprenorphine. So there is still sometimes a challenge of finding a provider that will prescribe buprenorphine. So those are some challenges. We've been working with, a lot of folks have been working with our jails and corrections to ensure people have access to MAT while they're there, because the risk of overdose when they leave incarceration is very high. So that's another thing that folks have been working on. But as far as the time frame for being on MAT, very variable, very individual dependent. And, it's important that people hopefully have other structures and supports and things figured out, and they're far along in their recovery. I think I hear from people who work in addiction and work in opioid treatment that, you have people go off successfully, and then you'll have someone who was very stable for a very long time, had a lot of recovery supports, and then stopped whatever their medication was, and then ended up having an overdose, right? So there, it can happen, and we don't know how to predict that with much certainty at this point. So very individual. I do think it can be challenging. I mean, I meet with people talking about their medications, and I see in their medical chart records that we get, sometimes they'll just have their clinician telling them they should taper off their methadone without any rationale, besides that they don't like methadone, which we're hoping with education we can help that, but that can be really challenging for individuals who have been able to access these types of treatments, then feeling that stigma when they go in for other types of care. I'll pause there. Questions? Any other experiences to share about that? One of the things that comes up is around abuse or misuse of medications for opioid use disorder, and you heard Kat talk about it in her in that earlier video. People can misuse it, and we saw in the chat earlier an individual got their buprenorphine from their dealer, and we see that a lot. Not a lot. We've seen that certainly it happens. So it's really difficult to know what the true rates of diversion are. Diversion is giving or selling your medication to somebody else. And sometimes like we hear that it's really altruistic, like I have Suboxone because I'm in treatment, or I'm getting this from my physician, and my, partner hasn't been able to go in, or they don't have insurance, or they're afraid, or whatever. So I'm splitting my dose with them to keep them out of withdrawal, to keep them from being sick. Right. So we do hear that from clients sometimes as well. And so there's some strategies to minimize that as a prescribing clinician, and it's to limit the amounts that are prescribed at a time, to have them come in for pill checks or bottle checks. That's what we do at our opioid treatment program, where individuals who are allowed take-home doses can randomly be selected to come in and make sure they have the amount that they should have, and that's to avoid diversion. It's really tricky because you want to be person-centered, and you want to trust everybody and not have them feel stigmatized by needing bottle checks and urine drug screens and that type of thing. Some of this is federally regulated, especially as it relates to opioid treatment programs. The frequency with which that has to happen is regulated, not optional. And so there are some challenges around that. There has been some work internationally trying to provide broader access to methadone, not just in an opioid treatment program. We talked earlier about how they're located sort of in those metro hubs. And so would there be a way to distribute methadone maybe to more rural locations, maybe partnering with community pharmacies, that type of thing in the future? We'll see if that ever comes to fruition. So then I see a question in the chat. What would you say to someone whose partner has not been able to access the medication? Someone who's sharing their own with their partner. Well, I think it's important for them to know that sharing a controlled substance prescription is illegal, so they should be aware of that, just in case there are ramifications. I think what I would try to work on is, what are the barriers for that individual that are preventing them from getting their own treatment? And so are there ways we could get them connected either to insurance or to a provider that can provide the medication for them, or kind of what's the barrier? And that's what I would try to do to make sure that they would have access. One other thing I wanted to mention, because Kat said it in her video interview as well, is around, you're just, replacing one thing with another. And as she said, like, yes, I am. And the thing I'm replacing it with is helping me lead a, a fantastic life. And so I think that is important. I think it's hard for us, many of us grew up with the Minnesota model of, abstinence only. And even within the recovery community, there are groups, where individuals using medications for opioid use disorder feel stigmatized, even within some of the recovery community, like AA, NA, some of those groups as well. So I think it's important to remember that there's many paths to recovery and improved quality of life, and that using a prescription methadone or buprenorphine is tremendously more safe than using off the street right now, especially for individuals who inject. So yes, it's a medication, and yes, you may be on it for life. And maybe that doesn't feel great. Maybe you don't like to think like people would need that, but if it helps keep people healthy, keeps them from overdosing and dying, and reduces crime and infection, and saves us as a community money, I think there's a lot of reason that we would want to do that. But we also want to make sure it's not diverted and hopefully not misused. So to help people with that. Okay, just wanted to mention naloxone or Narcan. All of our clients and folks who either have an opioid use disorder, live with someone, or are near someone, or care for people with opioid use disorder should have naloxone available. In the US, it comes as an injectable that you inject in the muscle, or as a spray that you spray in the nose. So I see a question in the chat around son using other substances, but not opioids, and we're told harm reduction doesn't work for the teenage brain. Is there an age limit? Could you tell me more about that doesn't work for the teenage brain? I'm not quite sure what that means. So I'll hold on until you can either unmute, or if you want to chat in more about what you mean by that. And while we wait for that, going back to the naloxone or the Narcan, So how that works is, like we talked about when I had the little receptor, is if you have an opioid sitting on that receptor, what happens if you have an overdose is you stop breathing. And if you stop breathing long enough, then your heart will stop. And that's when people have an overdose death. But the first thing that happens if you have that overdose is really that slowing and then stopping of the breathing. And so what the Narcan or naloxone does is it kicks that opioid off the receptor and reverses that so you can breathe again. And so I think a few important things are that depending on the dose and what people are using, they may require more than one dose of naloxone, not all at once, but they may feel better or reverse the overdose, think they're okay, and then 45 minutes later, they're back out because they still have whatever that opioid was in their system, and the naloxone is worn off. So if somebody uses naloxone or they'd be administering it with someone else, they should seek medical attention to make sure that they're okay. So that is one point I wanted to make. And then the other point is that if you reverse an overdose with naloxone or Narcan, and you kick those opioids off that receptor, right? And you reverse it, all of a sudden they're in precipitated withdrawal, right? So they will very likely, depending on the dose of naloxone, they feel really bad, really crappy. And their first instinct is going to be to use again, which makes total sense, which is why in detox and withdrawal management and in the emergency departments, we are prescribing buprenorphine right away to get that on board and help reduce that withdrawal, that precipitated withdrawal, and get them started on that. So I think that's an important thing, because I think if you're a first responder or a family member and you reverse an overdose, you think, oh, good, we reversed it, we're all good. But then, they walk out the door and go use again. It's because they're in withdrawal, and that's going to be their first instinct. So I think that's just important to think about. Going back to the chat around the harm reduction, advice to someone whose doctor wants to put them on methadone for pain management. Oh, I'll get to that. Back to that original question about the teenage brain. Better strategies for, so Jennifer, do you mean like they are not recommending medication for opioid use disorder, or what are they not recommending? Because when I think about harm reduction, go ahead.
Yeah, so he wasn't using opioids. He was using whatever he could get his hands on, but they were just saying that harm reduction just in general, and this was his treatment facility, doesn't work for teenagers, and abstinence is just a better avenue to pursue. So I was just wondering if you have found that for opioids, if someone is 15, 17, 19, if these medications work for teenagers, if they were to be using opioids.
Gotcha. Thank you for clarifying that. So I'll start off by saying I have never worked with anybody less than 19. So with that caveat, I don't know the answer. As far as medications for opioid use disorder, the studies are in folks that are adults that were in the trials. I know of people prescribing for people that are like 16, 17 who have a very long history of use of opioids with very adverse outcomes, including overdoses. So it's always going to be that risk benefit. When you said harm reduction, I was thinking more broadly, like if somebody is maybe they're not intentionally using opioids, but maybe they're injecting methamphetamine. Well, still having naloxone available would be good in case they unintentionally got an opioid. Using sterile equipment like sterile syringes and sterile needles would still be beneficial to reduce infection. But as far as using medications for opioid use disorder in youth, the evidence base isn't great. So we just don't have as much in the way of studies. So I think it's probably going to be a one-to-one or a one-on-one sort of conversation about that. And also exploring, like we talked about earlier, in addition to the substance use, are there other factors with mental health that maybe could be managed, and skill development and different things that they want to target first with abstinence. So I also want to clarify, just to be very clear, that methadone and buprenorphine work for opioid use disorder. They don't work for other use disorders. They're specifically for that opioid receptor in the brain. So that
Yep.
wasn't probably not a satisfactory answer, but yeah.
No, it's all good. It was just, yeah, I was, yeah, I'm very clear about the, opioids versus not. It was just, yeah, just different strategies. Thank you.
Yeah, you bet. And it doesn't mean that you can't take an abstinence-based approach for an individual, especially an adult who prefers that route, right? You work with people where they are and what they want to do. And so I think there's not the one size fits all. And I think as you get into youth, it gets trickier because we just have less data about what works. I did get a direct message. What is advice for someone who wants to put them on methadone for pain management? So methadone for pain management can be a good option if somebody's going to be on opioids for a period of time for chronic pain, maybe cancer pain, other types of pain. So if somebody already has an opioid use disorder and they're on methadone for an opioid use disorder at an opioid treatment program, then their pain doctor would take over that prescribing, because we wouldn't both be prescribing that. But it can be a very much a reasonable option for pain as well. And that doesn't require any specific training. Any physician who's managing pain could prescribe methadone for pain. It's just very restrictive once it's being prescribed for opioid use disorder. Also wanted to talk about, how do we contribute to stigma? You heard Kat's message about, you're substituting this with that. What else have you heard? How do you think in your communities or in your job situation, what have you seen that's stigmatizing for individuals with substance use disorders, maybe specifically opioid use disorder? You can feel free to chat it in. Anybody? Have you heard stigmatizing language or not using person-centered language? Thank you for that. Absolutely. I think that is one of the things that we can do. I think another thing we can do to try to reduce stigma is to really know what the research says. That's why I kind of call this the money slide, is like, knowing the data, knowing that if we use medications for opioid use disorder, the research tells us that it reduces use, reduces death, reduces crime, reduces infection, saves us money as a community, all while helping the individual with their social functioning, treatment, and accessing the services that they need. So that's why we do it. Because in opioid use disorder, it works better than abstinence for most people. So I think knowing these facts and kind of committing this to memory helps you understand and helps you educate others about why we use it. I think, knowing about how it can impact dependence and get us back to baseline so people can function. Into the comments in the chat, yeah, what's some of the person first recovery focused language we can use or avoid? So instead of using stigmatizing language like junkie or drunk or addict, saying an individual with a substance use disorder, and certainly people can identify themselves however they prefer, but that we would talk about them in a more person-centered way. Trying to avoid that clean and dirty language. So like when we talk about urine drug screens, instead of it being clean or dirty, we'll usually say it, you know, contains X, Y, and Z, and either is consistent or inconsistent or positive or negative. So trying to avoid that clean and dirty because, you know, people don't want to be described as dirty. And then rather than saying substitution therapy, you could say treatment or medication for opioid use disorder is more destigmatizing. So, what are your ideas? Any experiences anybody's willing to share either off mute or in the chat around how we can reduce stigma and help people access treatment? Anybody want to refute the anything I said or share an alternative perspective that we could learn from? I'm just going to grab the eval link so I can put it in the chat. I've been babbling away here. Thanks, Andrea, for letting me know. I was on mute. Okay, I am going to start over. I put the evaluation link in the chat. If you could please fill that out, it really helps us improve our offerings. So that would be great. I also had a question about naloxone training. So I'm going to see if it's in the standard slides here. Otherwise, I'll put a link to the extension website where you can access that. Either there's online material, and there's also, you can request to actually have a training for you or your specific group. My email and phone number are on this slide, so you can put that in the chat as well. So you can feel free to reach out if you have questions after this that you didn't think about or you didn't want to share in front of the group. Okay, we already talked about the eval. We have some upcoming webinars. And there are several in Spanish. And then let's see here, mental health, tips and tools. I know we have naloxone training. I'm just seeing if it's in these slides. Otherwise, we'll go find it. So University of Minnesota Extension has a number of resources, and it looks like there's one on harm reduction, but I don't see one specifically on naloxone. So I will find that for the individual who asked. If you could email me, I will get you that link just in case we get disconnected. The extension links are here as well. What other questions or ideas would folks like to share or ask in the chat, or feel free to unmute as well? The presentation, I believe, will be sent out. I will ask Mary Jo, who is helping organize this, to see if it'll automatically be sent out or if like a link to it can be posted on the website. So I'm just making some notes here. No problem. And everybody registered, so we should have your email. So I will check on the naloxone training, get the presentation and the slides. I'll ask Mary Jo about getting those sent out. Anything else? And sometimes at these presentations, maybe you work with another group of people you think might benefit from some training, like the naloxone training you mentioned, or this training or other training. Please feel free to reach out and we can get something scheduled as well. All right. Would craft training be a helpful topic? You'll have to tell me what craft training is. I'm not familiar.
Oh, thanks. It's like a family training on how to engage your person towards seeking treatment, and with like a loving approach rather than a tough love approach. And it's been shown that if you're looking for change talk and finding the right moment, you can encourage your person to seek help.
Oh, thank you for, is it an acronym for something?
I think it's community and family addiction training, maybe. Think something like that.
Yeah. Well, it sounds like it might be helpful. Or is it something that you offer? Are you asking, is it something that this group might be interested in? Or I'm wondering if it already does something.
Yeah, so I attend a group therapy kind of session once a week, but it's put on by there's a local organization called Thrive. And they work with families, not with the person with substance use disorder.
Thank you for sharing that. I will definitely send that back and see if Extension is already working with them or if that might be something for the future. So thank you for that. Other questions or ideas? It's a pretty quiet group. All right. Hearing none, I'll just ask that you please fill out that evaluation, help us do better. Please be in touch if you have other questions, and I will follow up regarding the craft training, the slides and recording, and then the naloxone training as well. So thank you so much for your time and for being here with us today. Have a wonderful day.
Thank you.
Thank you.